All right, I have 1 o'clock Eastern on my watch, so I think we'll go ahead and get started, and people can join as they're trickling in. Welcome to the Neurocritical Care Society Pharmacy Journal Club. My name is Corinne Berger, and I'll be one of your moderators today. I'm joined by Colleen Barthel and Kim Levisser of Franklin. We also have two critical care pharmacy resident presenters, Chandler Allen and Megan McQuigg. And we are also participating in the Journal Club on Twitter. So, or X, if you guys are on Twitter or X, please feel free to follow along. Kim is going to be moderating online for us using
Stop it.
hashtag NCSFarmJC. Just a couple of housekeeping before we get started. If everyone can just make sure you all are muted. That way we're not interfering with the presenters. We will take questions at the end of each presentation.
Stop.
And I might start muting people as I see them. So feel free to type your questions into the chat box, or you're welcome to unmute yourself and ask your question. And with that, I'm going to turn it over to our first presenter, who's Dr. Chandler Allen, a critical care pharmacy resident at Ochsner Medical Center. And Chandler, you are welcome to go ahead and share your screen.
All right. All right, can everyone see the screen?
Yep, looks good.
Good afternoon, everyone. My name is Chandler Allen. I'm the current PGY2 critical care pharmacy resident here at Ochsner Medical Center in New Orleans, Louisiana. And today I'll be going through the SAHARA trial, which is the liberal or restrictive transfusion study in aneurysmal subarachnoid hemorrhage patients. So can I go to the next slide? Okay. So by the end of this presentation, I would like everyone to be able to recognize the gaps in knowledge regarding anemia in subarachnoid hemorrhage patients. We're going to explore previous literature regarding anemia in the critically ill population. And then we'll analyze the SAHARA trial and how this impacts outcomes in patients with subarachnoid hemorrhage. So a little bit of background, subarachnoid hemorrhage, especially in the aneurysmal origin, is a devastating form of stroke, and this accounts for 3% of all of hemorrhagic strokes. And then our risk factors include patients over the age of 50, our female population, those with hypertension, along with those with alcohol use. And then early mortality in this population is estimated at 25 to 35%. And then a critical issue in these patients is a full recovery, and less than 1/3 of these patients make a full recovery. And then anemia occurs in half of this patient population. So anemia in the setting of subarachnoid hemorrhage, it compromises oxygen delivery to the injured parts and at-risk brain tissue. And then by reducing this oxygen delivery, anemia can cause early and delayed neurological insults. And this follows aneurysm rupture, and this can contribute to our patients with poor recovery. Subarachnoid hemorrhage also activates inflammatory responses, and this can lead to anemia and inflammation in our patients. But transfusion, on the other hand, can also help mitigate these problems by increasing the oxygen carrying capacity of the blood, and this can help with perfusion, which can potentially reduce the risk of delayed cerebral ischemia. And this raises the question about the appropriate hemoglobin threshold in this patient population. So currently, there's no great guidance on how to treat these patients with hemoglobin thresholds. So we have the Neurocritical Care Society guidelines that say they have an insufficient evidence to provide a recommendation for using a transfusion threshold that's higher than a hemoglobin of 7. And then similarly, the American Heart Association or the American Stroke Association, they state that they have the optimal hemoglobin thresholds in the indication for transfusion remain unknown. And then looking to our European Stroke Organization guidelines, they have no stance on the hemoglobin threshold. For our background literature, back in the 90s, we have the TRIC trial, which included 838 patients that were in the ICU over 24 hours. And they compared a group with the liberal hemoglobin threshold of less than 10 compared to a restrictive hemoglobin threshold of less than 7. And they looked at death at 30 days as their primary outcome, with a lower amount occurring in the restrictive group. But they state that the critically ill population should receive red blood cell transfusions if hemoglobin falls below 7, and their goal should be 7 to 9. And then we fast forward into like current years, 2024 and 2025. We have the TRAIN trial. This is 820 patients in a mixed population that included TBI, subarachnoids, and ICH patients. And these patients had a hemoglobin of 9 or less. And they compared a liberal transfusion threshold of less than 9 and a restrictive of less than 7. And they looked at unfavorable neurological outcomes in these patients, with the liberal group having less neurological unfavorable outcomes. But they say that patients with anemia and brain injury should have a threshold of 9. And then in our HeMotion trial, included 742 patients, and these were moderate to severe TBI patients with a liberal goal of less than 10 and a restrictive threshold of less than 7. And they also looked at unfavorable neurological outcomes at 6 months, and they found that the liberal group had less unfavorable outcomes. And they state that the hemoglobin goal of less than 10 does not decrease the risk of unfavorable outcomes. Which leads us to our trial today, which is the SAHARA trial, and they questioned, does the liberal strategy of blood transfusion compared to a restrictive strategy reduce unfavorable neurological outcomes in those with acute aneurysmal subarachnoid hemorrhage? So they included patients at 23 centers between 2015 and 2023 who were over the age of 18 with a first ever aneurysmal subarachnoid hemorrhage. And these patients also had a hemoglobin of 10 or less within the first 10 days after their admission. And then they excluded patients with active bleeding with hemodynamic instability. Patients with contraindication or known objection to blood transfusions were also excluded, as well as excluding patients with subarachnoid hemorrhage due to mycotic aneurysms, infundibulum, and vascular malformations. And then they excluded patients that had a family or physician decision to withdraw or withhold medical care. So overall, they screened 1,770 patients with a first ever aneurysmal subarachnoid hemorrhage with a hemoglobin of 10 or less. In total, they excluded 1,028 patients. And I do want to point out that half of these patients were excluded because of the medical therapy being withheld. And then also the other half of that group having no consent or declined consent. So overall, they randomized 742 patients, 364 patients to the liberal transfusion group, and 361 to the restrictive transfusion group. So the liberal transfusion strategy is whenever a patient's hemoglobin was 10 or less, they would transfuse. And then in the restrictive transfusion strategy, they had a hemoglobin threshold of 8 or less. And whenever this would drop, they would receive 1 unit of leuko-reduced red blood cells, one at a time. And this assigned strategy was applied for 21 days. And this is due to the first 21 days of being in the most high-risk patient group. So their primary endpoint was looking at the proportion of patients with unfavorable neurological outcomes. And this is defined as a modified Rankin scale score of 4 or more. And this was looked at 12 months. And then their secondary endpoints include functional independence at 12 months, their European Quality of Life 5-dimension, 5-level questionnaire at 12 months, death in the hospital, delayed cerebral ischemia, radiographic vasospasms, as well as new cerebral infarct. For their statistical analysis, they calculated that they needed 740 patients to meet 80% power and to show a 25% relative reduction in the primary analysis. They used a binomial generalized linear fixed model for their primary outcome. And then for their secondary outcomes, they included linear generalized mixed models, log binomials, and then they used means, quartile regressions, and median differences. So this slide is more of a patient baseline characteristics. And as you can see, they were pretty well matched at baseline. And there were more females, but this is expected with the disease state at hand. And then this slide is from an aneurysmal standpoint with baseline characteristics. Subarachnoid hemorrhage severity measures, such as modified Fisher scale and then the World Federation of Neurological Surgeons scale score, were well balanced. And then there were more patients undergoing endovascular treatment, and then half of this population was receiving vasopressors on admission. The trial found no difference in their primary outcome, looking at unfavorable neurological functional outcome at 12 months. And again, this was defined as a modified Rankin scale of 4 or greater. And then the liberal strategy, they had 33.5%. And then their restrictive strategy, they had 37.7%, with a risk ratio of 0.88 and a p-value of 0.22. And now, while this is a numerical difference between the two groups, I do point out that this isn't a statistically significant difference. So this is a chart that they included in the trial, looking at the scores of each groups on the modified Rankin scale. And the first group on the top is the liberal strategy group, and the bottom is the restrictive strategy group. And then each color is coordinated with a different percentage of patients within that modified Rankin scale. But functional outcomes using the full modified Rankin scale distribution shows that it favored the liberal group with an odds ratio of 0.82. But again, this isn't statistically significant, but it is suggestive of a possible trend between the outcome. So in a pre-specified subgroup analysis, some trends also favored the liberal strategy, but this included patients over the age of 55. Our male population, and as you can think about it, our female population is a big group in this like subarachnoid hemorrhage. We can also see it in our World Federation Neurological Surgeon scale. And then if we look down at the bottom, we can see this as well in our patients that received a neurological aneurysm management. And then looking at our secondary outcomes, so the first one is the Functional Independence Measure score. So as you can see, there's no differences between the two groups, as well as the European Quality of Life 5-dimension at 12 months in these patients. And then if you look at the new radiographic vasospasm, there is a difference between the two groups, with the liberal strategy having 31.5%, and then the restrictive strategy showing 40.7%. So in conclusion, the study says that in patients with aneurysmal subarachnoid hemorrhage and anemia, a liberal strategy of red cell transfusion over the first 21 days of hospitalization did not result in a lower risk of an unfavorable outcome at 12 months compared to a restrictive strategy. But there are several strengths to this study, is that they had high protocol adherence as well as minimal loss to follow-up. This also was a multi-center across 3 countries and several centers, which can help with the generalizability of the study. And they also looked at a large number of secondary outcomes like we discussed. And they also included the subgroup analysis to see which of those groups inside of the primary outcome could show any differences. The study does have several limitations as well. They don't discuss the use of any other blood products like platelets or cryoprecipitate, which, I feel like in some institutions they do use those as well as our red blood cell transfusions. They also didn't meet power. So this was an underrepresented, or they wanted to show a 25% relative reduction in the primary outcome. So they wanted to find a large treatment effect, since they didn't meet this, it just shows that could possibly be a false negative. Sorry, but it also does not prove no clinical benefit in these groups. Treatment teams were also not blinded to the group assignment, but this is also kind of hard to do whenever a blood bank has to approve whenever a patient is receiving red blood cell transfusions. They also didn't use a classic restrictive hemoglobin goal. So, like in the beginning when I talked about the TRICK trial, they have a hemoglobin threshold of 7. But in these patients, they have an increased risk of ischemia. So it could have possibly been, um, changed to a higher goal based on that. But for my takeaway, while liberal transfusion to maintain a hemoglobin goal of up to 10 appears safe, it did not significantly improve 12-month neurological outcomes over the restrictive threshold of 8. So, in the context of resources and potential transfusion risks, restrictive transfusion to me remains a valid strategy. But we do currently have 3 trials, so the HeMotion, the TRAIN, and now the SAHARA trial that shows a slight trend towards a liberal threshold for those with brain-related injury. But there also needs to be a consideration from a blood bank availability in hospitals. So, for example, here at Ochsner, our blood bank has to approve the use of our red blood cells, and they also come over the intercom saying, there's a shortage going on. But then there also needs to be more studies to clarify if liberal transfusion offers a real clinical gain, especially in our high-risk patients, like those with vasospasm risks or delayed cerebral ischemia. And thank you for allowing me to present, and I'll take any questions.
Thanks so much, Dr. Allen, for summarizing that. For the audience, feel free to put your questions in the chat or on Twitter, or you can go ahead and unmute yourselves. I can get us started. I'm glad you mentioned the hemoglobin because to me it was a little bit confusing what we were actually comparing. They did talk about, the hemoglobin was lower, it was like 7.4 or something like that in the restricted group, but then they have this figure,
Mhm.
I think it's figure 1 that actually shows the minimum hemoglobin levels from randomization through day 21. And it looks like, it's kind of above 9 in both groups. So what are your thoughts about kind of what the comparators were and how that, kind of impacts the takeaway from the study?
Yeah, I think like because that was at baseline. I can go back to the slide too. This one, correct?
Yeah,
Like,
they did provide the hemoglobin at randomization, like the baseline, but then they
Mhm.
also provide a figure that kind of after randomization plots
Oh, yeah,
out
yeah.
all of the hemoglobins between the two groups.
Yes. And like the trends by the groups and stuff, like throughout the treatment duration. I think that it's interesting to say because like when they do find like they go through also the percentage of patients that received transfusions throughout the treatment. Um, I think I feel like it's not like more or less a clinical like impact on how much they use, but I think it's interesting to see that overall, like we do say, like see like in our subarachnoid patients, like they do have anemia, but also like this patient population in this study was similar between groups.
Yeah, and I wonder, if we can call it restrictive. It wasn't clear to me how much blood products actually that
Mhm.
restrictive group got because it sort of looks like their hemoglobin is pretty high throughout
Mhm.
the 21 days. It's definitely lower than the liberal group, and it looks like
Right.
it's kind of hanging around right around 9. But it's not at 8 or 7.
Correct.
So
It's not a big difference between the two groups.
yeah. Sorry, was there did anybody have a
Want to
question?
turn the other way?
Oh, okay, I'm gonna mute. Okay, let's look in the chat. Aaron's asking, could the advantage of lower blood viscosity be counterbalancing any benefit of having a slightly higher hemoglobin? And any thoughts on the interplay there? This is like the old
Yeah, from
school
like a
Triple H.
I mean, I think that there's a possibility of an advantage of lower viscosity, but I think the like downside to that is that they're not having enough oxygen capacity or like, an oxygen delivery to that underperfused area. I think like I know if like there's a possibility, but I think also like you have to count like, look at the risk and benefit of giving red blood cells and then also the risk of not giving it with underperfused areas. So like then you have like the increased risk of vasospasm and DCI.
Yeah, and I think back in the day when we or when we, were thinking about Triple H and blood viscosity, being something we target, and I think more in like modern care, we're not doing that. I was actually surprised, to be honest, that there was enough equipoise about this question.
Mhm.
That kind of leads me to my second question. You know, what was this something that at your center that was like a question? What are you guys doing at your center for patients with subarachnoid hemorrhage? Are you using a more liberal approach, or are you using like kind of our standard 7 or 8 for transfusion?
Yeah, so currently here at Ochsner, like because the like national red blood cell shortage, we have the threshold at 7. But it's like, whenever you also look at this too, like going all the way back into the trick trial that we talked about, I think, that study didn't include a very large population in, the neurological injury population. So like that's kind of, where the question is today of like, okay, well, in these patients that do have these neurological injuries, can we possibly increase the hemoglobin and, improve outcomes?
So if there wasn't a red blood cell shortage, based on this study, would you change that recommendation at Ochsner?
Currently, I would not. I mean, like you have these, trends and, it's a lot of like hypothesis generating to say, oh, well, that's interesting. There is like, a slight numerical difference, but, overall, there's not a statistically significant difference to like change practice. Like I
Yeah,
think like it's definitely like, I would like to see more um, you know, studies on these population and, groups of patients, but like currently from the study, I would not.
yeah, I think that's reasonable. And I don't know how much more room for more data or how much more equipoise there is on this topic.
Yeah.
Um, It was interesting too that there were so many patients on vasopressors because the incidence, even of just radiographic vasospasm, I think was like 30% or something like that.
Mhm.
And like DCI was, 13 and 15%, but then almost half of the study population was on pressors. So I guess it's not really clear to me if they were on pressors for another indication, and
Yeah, the study
does
didn't go into
that
in depth
no,
on that either.
and does that affect like or does that have confound anything with respect to giving, potential resuscitation or giving red blood cells to these patients?
Correct, exactly. Yeah.
Cool. Those are all my questions. Definitely, if you guys want to throw in the chat, if anybody is using liberal, restrictive, or has other opinions. But if nobody has any other questions, thanks so much for the presentation. And we'll go ahead and give you guys a second to switch over to our next presenter. Uh, yeah, and then
Mhm.
some agreement that maybe we can close the door on giving these liberal blood transfusions to everybody. We don't do this in my practice or where I practiced previously.
Mhm.
And again, I was surprised that that maybe there are institutions that are still thinking about this. Thanks so much. And Dr. McQuigg, whenever you're ready, you can go ahead and take over the screen share. Okay. All
Okay, is
right.
everyone
So,
are you able to
yes.
see my screen? Okay,
Perfectly.
perfect.
Thank you. So just as a reminder, if you could please mute yourself if you're not talking, but of course at the end, you're welcome to unmute yourself for questions. Please follow along on Twitter, usually using hashtag NCSPharmJC. And now we'll roll into our second presenter, Dr. Megan McQuigg, who's a PGY2 critical care resident at University Hospitals, hold on, Cleveland Medical Center, and she will be presenting on early versus delayed acetylsalicylic acid after spontaneous ICH.
Thank you for the introduction. So, as she mentioned, I will be covering the eSTART trial, which was evaluating the safety and efficacy of early versus delayed acetylsalicylic acid after surgery for spontaneous intracerebral hemorrhage, or the eSTART trial. And beginning with a brief background, patients with a recent spontaneous intracerebral hemorrhage, or an ICH, have been found to be at an increased risk for experiencing major cardiovascular, cerebrovascular, and deep vein thrombosis events. And it has been found that the incidence of in-hospital thromboembolic complications to occur at a rate of 7%, as well as the events have been found to occur more frequently in the first month after experiencing an ICH. Antiplatelet therapy has been found to be an effective method for preventing ischemic cardiovascular and cerebrovascular events, as well as peripheral vascular events, including deep vein thrombosis and pulmonary embolism, particularly among patients who have been deemed to be at high risk for experiencing these events. However, the initiation of antiplatelet therapy is often delayed within this patient population, and some potential contributing factors for this delay include a concern for worsening hemorrhage or other bleeding postoperatively. And currently, no guidelines or consensus statements discuss the initiation of postoperative antiplatelet therapy. And now I'd like to briefly review the outcomes from previous studies that are directly relevant to the study I will be discussing today. And the first trial I'd like to highlight is the RESTART trial, or the effects of antiplatelet therapy after stroke due to intracerebral hemorrhage. And this was a randomized open-label blinded endpoint parallel group trial evaluating patients aged 18 years or older that were taking a antithrombotic therapy at their onset of their ICH. And two study groups were evaluated, the first being a START group in which oral aspirin and or dipyridamole or clopidogrel were initiated. And then the AVOID group was the second group evaluated, in which antiplatelet therapy was avoided entirely. And the primary outcome evaluated was the incidence of recurrent symptomatic hemorrhage for up to 5 years after the initial event. And so this study found that the recurrence of intracerebral hemorrhage occurred at a similar rate between groups, the START and AVOID group, occurring at a rate of 4% in the START group as compared to 9% in the AVOID group. And they also found similar rates of major hemorrhagic events occurring at a rate of 7% in the START group versus 9% in the AVOID group. And major occlusive vascular events also occurred at a similar rate, being 15% versus 14%. And so these authors concluded that restarting antiplatelet therapy was safe, as evidenced by similar rates of recurrence of the intracerebral hemorrhage or other major hemorrhagic events. However, there did not show to be a benefit in decreasing major occlusive vascular events with early initiation. And the second trial I'd like to highlight is the Mr. Clean Med trial, or the safety and efficacy of aspirin, unfractionated heparin, both or neither during endovascular stroke treatment. And this was an open label, multi-center randomized control trial evaluating patients aged 18 years or older. And I would like to highlight that this population is different versus the article I'm highlighting today, being that they're evaluating patients presenting with an ischemic stroke. However, I think the intervention is relevant to today's discussion. So these were patients presenting with an ischemic stroke and underwent a endovascular treatment, and they had a baseline NIHSS of 2 or greater and a CT or MRI ruling out intracranial hemorrhage. And there were 2 main interventions evaluated, in which paraprocedurally IV aspirin or no aspirin was administered. And then the second intervention was either giving moderate dose unfractionated heparin, low dose unfractionated heparin, or no unfractionated heparin at all. And their primary outcome evaluated was patients' MRS at 90 days after the event, and then for safety, the incidence of symptomatic ICH. And so symptomatic ICH occurred at a rate of 14% in the aspirin group versus 7% in the no aspirin group. And then it also occurred at an increased rate in the unfractionated heparin group, occurring at a rate of 13% versus 7%. Indicating an increased risk of symptomatic ICH after initiation of these interventions. And there was a trend towards worse MRS scores in aspirin and the unfractionated heparin group as well. And so these authors concluded that periprocedural IV aspirin and unfractionated heparin during endovascular stroke treatment were both associated with an increased risk of intracranial hemorrhage without evidence for beneficial effect on functional outcome. And so with these trials really bringing to question whether or not aspirin is safe or ineffective, specifically in the ICH population, that brings us to the trial of today's focus, which is the eSTART trial. And their study question was, does early initiation of antiplatelet therapy after surgery for spontaneous intracranial hemorrhage reduce the occurrence of major cerebrovascular, cardiovascular, and peripheral vascular events, and without increasing the risk of bleeding? And this was a prospective, open-label, blinded endpoint randomized trial performed at 8 comprehensive stroke centers within China. And the intervention for both study groups was 100 milligrams of acetylsalicylic acid, or ASA, tablets given once daily. And there's 2 different time points for the initiation of aspirin. And the first being the early start group, in which it was started on postoperative day 3, and it was continued until postoperative day 90. And then the second group was the late start group, in which aspirin was started on postoperative day 30 and continued until postoperative day 90. The primary efficacy outcome evaluated by this study was a composite of new major cardiovascular, cerebrovascular, and peripheral vascular events within 90 days after surgery undergoing for their spontaneous intracranial hemorrhage. And the primary safety outcome evaluated was the incidence of any new intracranial bleeding within 90 days after surgery. And relevant secondary endpoints included the rate of death within 90 days after surgery, the rates of in-hospital death, and then 90-day functional outcomes as assessed by modified Rankin scores and Glasgow outcome scores. Statistical analyses used for categorical variables was the chi-square test, or the Fisher's exact test, and then the t-test, or Wilcoxon rank sum test, for continuous variables. And the study also performed time to event analyses using Kaplan-Meier curves and log rank tests. And a 2-sided p-value of less than 0.05 was regarded as the threshold for meeting statistical significance. They also performed a power calculation and estimated that they needed to collect a total of 250 patients in order to detect a 50% relative risk reduction in the primary outcome in the early start group. And now briefly reviewing the inclusion criteria. Patients were included if they were aged greater than 18 years of age, but were less than 70 years old. They experienced a ICH of a non-traumatic cause, and they were deemed to be at a high risk for experiencing ischemic events. And so there's 2 main criteria for meeting this high risk category, and that they have a history of cerebral infarction, transient ischemic attack, coronary heart disease, or myocardial infarction, or having a risk score of 10% on the 10-year ASCVD risk estimator. And then lastly, patients were also deemed to be at high risk of experiencing a VTE event, as evidenced by a postoperative Caprini risk score of greater than 2. Key exclusion criteria that I'd like to highlight were that any patients that experienced the major efficacy or safety outcome after their ICH event, however, prior to randomization, were excluded for evaluation. And they also excluded patients that were taking oral antithrombotic therapy prior to their spontaneous ICH. So this included our traditional antithrombotic therapy, as well as vitamin K antagonists or warfarin, and novel anticoagulants such as the Bigatran and rivaroxaban, regardless of whether or not the patient was taking an antiplatelet agent. So this study was really evaluating a new start of antithrombotic medication, being aspirin, really excluding patients who had pre-existing aspirin or anticoagulation on board prior to their event. And now moving on to results, a total of 7,323 patients were screened. And of those patients, a total of 269 patients were included in the study for analysis. 134 patients were allocated in the early start group, and 135 patients were allocated to the late start group. And since such a significant number of patients were excluded, the most frequent exclusion criteria I'd like to highlight was patients that did not undergo neurosurgical procedure was the most frequent reason, being about 4,500 patients excluded for this reason. And then the second most common reason for exclusion were patients not meeting those age criteria, so either less than 18 years of age or greater than 70 years of age. And then about 775 patients were excluded because their cause of ICH was deemed to be traumatic. And now briefly reviewing patient baseline characteristics at the onset of their event. The study cohort was comprised of patients with a median age of 60 years old and was primarily comprised of patients identifying as the male sex within both groups. And nearly all patients in both groups, with only 2 and 3 patients identifying as other ethnicity, were identified as Han Chinese patients. And now moving on to key past medical history and key characteristics I'd like to highlight were that a significant number of patients had the history of previous ischemic stroke, previous transient ischemic attack, or previous coronary heart disease. So these are frequent indications for secondary prophylaxis with aspirin. And I'd also like to highlight that only 22% of patients had previous antiplatelet therapy before hemorrhage. The authors did not specify their timing of evaluation for previous antiplatelet therapy before hemorrhage. So this may suggest that these patients had a pre-existing indication for aspirin secondary prophylaxis. And now reviewing event characteristics, you would classify these as a mild to moderate intracranial hemorrhage with an ICH score of about 2 to 3, depending on the volume and location of the bleed. So the patients had a median hematoma volume prior to surgery of 53 milliliters, referring to as a big bleed as compared to our other trials, such as the MISTY-3 and the CLEAR IVH trial, really having patients of 30 milliliters or less of a bleed. So a pretty significant hematoma volume. And then the baseline Glasgow Coma scale score before surgery was 11 for both groups, indicating moderate dysfunction at baseline prior to their surgical intervention. Now, quickly reviewing treatment characteristics, both groups received appropriate blood pressure treatment, as evidenced by a decrease in systolic blood pressure from 170 to 130 after their medical therapy and randomization. So reasonably within those accepted goals of 140 or 140 to 160. And also, I'd like to highlight that the majority of patients underwent a minimally invasive surgery, with 60% of patients in both groups undergoing a minimally invasive surgery, followed by craniotomy, and then the fewest amount of patients underwent a craniectomy. And now reviewing the primary outcome, which was the incidence of major cardiovascular, cerebrovascular, and peripheral vascular events. This occurred at a rate of 20% in the early start group versus 31% in the late start group. And the breakdown of each event type is depicted in this graph, but the benefit was primarily driven by a difference in major cardiovascular, cerebrovascular events, which occurred at a rate of 3% within the early start group versus 11% within the late start group. And the p-value is depicted at the bottom, which was 0.041, deemed to be statistically significant based on their predetermined threshold. And now looking at the subgroup analysis for that primary outcome, I really just wanted to highlight groups in which normal start was actually trended to be better. So key groups that I think are relevant in which it was trending to be better were patients who had no previous ischemic cardiovascular or cerebrovascular disease. So recalling that a significant number of patients in this study cohort had a pre-existing disease. So in those patients who did not have a pre-existing disease, normal start of aspirin was trended to be actually better for these patients. And then also surgical method may have been an additional factor impacting patient response, in which craniectomy, normal start of aspirin was also trended to be better. And now for safety outcomes, any intracranial bleeding within 90 days after surgery occurred at a similar rate between groups, at a rate of 1% versus 3%. And then any moderate or severe bleeding events within 90 days after surgery also occurred at a similar rate, being at 3% versus 4%. Other relevant secondary outcomes, death within 90 days after surgery was reduced in the early start group, occurring at a rate of 7% versus 16%. The rate of in-hospital death was comparable between groups. And then lastly, the patient's MRS score at 90 days after surgery, having an MRS of 0 to 3. Numerically, more patients in the early start group had a MRS meeting this criteria. However, this did not meet statistical significance. And then the Glasgow outcome score of 3 to 5. Numerically, more patients in the early start group also met this criteria. However, this was also not found to be statistically significant. So the author's conclusions were that in patients who underwent surgery for spontaneous intracranial hemorrhage and were deemed to be at high risk of postoperative ischemic events, the early initiation of antiplatelet therapy was deemed to be safe, and that there was no significant difference in the rate of new bleeding events, and this included both intracranial and extracranial bleeding events. It was also associated with a lower risk of major cardiovascular, cerebrovascular, or peripheral vascular events. And these findings do favor early initiation for antiplatelet therapy among patients who have an ICH and are deemed to be at a high risk of postoperative ischemic events. And now moving on to my critique and my clinical interpretation. First, reviewing some strengths that I noted in this trial, being that I think that the study groups were well balanced in regards to event and treatment characteristics, specifically focusing in on hematoma volume and the location of the hematoma, as well as the blood pressure management strategy. And I think that these are key characteristics impacting patient outcomes. So these management strategies and baseline characteristics being similar removes a potential confounding variable when looking at these results. And the trial also had a randomized design, as well as had a blinded endpoint in which it was assessed centrally by 3 study educators. So that helps to decrease the risk for bias. They utilized a intention to treat analysis, which also enhances external validity. And lastly, the aspirin dose utilized was 100 milligrams, which is relatively similar to typical dosing utilized in our practice typically for prevention regimens being 81 milligrams. So this, I think, aids with our application to our current clinical practice. Some key weaknesses that I noticed was that it was a relatively modest sample size with a total number of patients evaluated being 269 patients. And they also did not meet statistical power due to the event rate being different than what their predicted event rate was for their power analysis. Another key weakness that I noted was that venous thromboembolism prophylaxis use was not reported. And I think this is really relevant because it was a portion of their primary composite outcome. So I think seeing this would be able allow us to see if there's any trends or differences among the groups. I really would like to see if there was a difference in the timing of initiation or the agents or dosing utilized. And I did not note that the authors specified that there was like a standardization of VTE prophylaxis. So I think this is a key weakness impacting our interpretation of the results. I also think that the inclusion-exclusion criteria really limits the generalizability to other populations. The key thing is that only 4% of screened patients were enrolled. Over 7,000 patients were excluded. So this could raise the question if there was selection bias. And they also excluded patients aged greater than 7 years old. And I noted that other landmark ICH trials do not have a maximum age for inclusion, really just having a minimum age for inclusion. So I think this is a key difference with this trial. And also our patients aged 7 years and older are associated with having a poorer outcome with ICH. And so also ICH occurs in a large number of patients aged 7 years or older. So I think it would have been relevant to at least evaluate this population. And the last weakness that I noted was that many patients in the study cohort had a pre-existing indication for aspirin secondary prevention. The key past medical history being more than half of the patients had a history of transient ischemic attack. So this may have been a confounding variable in that they were already going to experience benefit as it was a known aspirin benefit group. And now moving on to my clinical interpretation of the study is that these findings suggest that for post-operative ICH patients deemed to be at high risk for ischemic complications, early initiation of aspirin, specifically on day 3 after surgery, is suggested to be both efficacious and safe in the short term, specifically 90 days after the event. So the application of clinical practice, I still think that the post-operative initiation of aspirin should not be routinely recommended for our patients with an ICH deemed to be at a high risk for ischemic complications. This study, this is due to those weaknesses that I highlighted previously, but there is a suggested benefit in patients who underwent craniotomy or minimally invasive surgery, or if they had pre-existing aspirin indications, however, were not antiplatelet prior to their event. Some next steps and methods for evaluating the questions raised by this study. I think we have an opportunity to perform a trial in a larger sample size. Of course, meeting power, allowing us to assess for meeting statistical significance. Importantly, evaluating a more diverse patient population, remembering that nearly all patients were identified as Han Chinese ethnicity, so looking to see within our patient care groups if this is deemed to be beneficial. And then I think lastly, there's a need to perform a trial like similar to this and collect relevant medication class use, specifically being VTE prophylaxis. So to summarize, the eSTART trial provides important evidence for supporting early aspirin initiation after ICH surgery among high-risk patients. However, I still think that the trial's limitations warrant cautious implementation and interpretation into our clinical practice. I think there needs to be further research into more diverse populations. However, I do think that the findings of this trial can be extrapolated into our current clinical practice. Specifically thinking of like a common discussion that comes up in practice is patients with a ICH and already on an antiplatelet therapy. This is a growing body of evidence showing that earlier initiation of antithrombotic therapy such as aspirin is shown to be safe. So showing that initiation of the antithrombotic therapy at 3 days is not associated with increased risk of harm for our patients. So I think that could be the main interpretation with this study. And with that, those are my references. I'd be happy to answer any questions anyone may have.
Thank you so much, Megan, for covering a very controversial topic for a lot of us. We seem to keep going back and forth on this. Colleen has a question that I'll piggyback off of. So she says, Megan, what's your current institution's practice regarding the use of aspirin after ICH? And I had the same question because I saw some of your conclusions were saying, basically this tells us it's safe, but your previous conclusion was, you don't want to routinely recommend it. So what are you guys currently doing?
So currently it's not standardized. It's really provider preference independent. And of course, like considering the surgeon who may have intervened upon the ICH. But I would be curious if your institutions have a standardized initiation.
We definitely don't, not my current or previous. I would be surprised, but really interested to hear if somebody really has protocolized this, because I think it's so patient and neurosurgeon specific, but definitely feel free to put in the chat if anybody has tackled this and won a protocol here. While people are thinking about that, I did have another question. Okay, no protocol tests. Thanks, Kim. What did you think of the intervention groups as far as like how they defined early versus late? Would that have been your preference, or are there different time periods that you would have wanted to study as well?
Yeah, that's a really great point. I think the early versus late is pretty extreme in my opinion, 3 days versus 30 days. I think maybe a more comparable late group may have been like 7 days or 14 days. Because I think like in my practice, that's sometimes like when we'll actually restart anti-platelet therapy. So thinking like standard care, I think that may help with like, I guess, interpretation of the results.
Yeah, I completely agree. I think we have studies now that have, told us that we don't have to be holding particularly antiplatelets forever and ever. So I think by day 30, that's so far out, but I would have loved if they could have done like a 3 versus 7 or 3 versus 14, because I think that's where three feels kind of early. Um, but it's hard to say when they compared it to 30 days, where I think people feel a lot more comfortable, but maybe that's how they were, where they felt that they would be able to um, consent and include sites easier. Um, I wrote the same comment as you said, like VTE prophylaxis question mark. That's really tough. How do you take that into some of the results, the fact that we don't really know what the sites did, and considering there is so much variability between sites and between surgeons?
Yeah, I was really interested to note that they did not include the intervention for like preventing the primary outcome, like a portion of it. So I think definitely looking at like the incidence of VTE within groups, it did occur at a similar rate. So perhaps they had similar VTE prophylaxis, but we currently don't know. So for that primary outcome, I honestly would really focus on like the major cerebrovascular and cardiovascular events, because that was the primary driver for the difference among groups.
That's good. Um, They did exclude patients who, already had a rebleeding event or a cardiovascular event before they ended up meeting that randomization. What do you think of that exclusion, and how, again, like you talked about the small patient population from, like, how many patients they screened, but how do you like apply this to those patients, if at all, or what do you think about their decision to exclude those patients?
I think like to exclude those patients, it kind of changes, I guess, the indication for aspirin, because these patients in this trial is kind of like a new start. In theory, they don't have, I guess, a clear indication for aspirin. I kind of raise the question, like patients who experience those events, they may have like a new indication for secondary prevention events. So I think that was appropriate to exclude them, because it's kind of evaluating a different population.
Yeah, I agree. I did see there were a number of patients excluded for that. That is something we always wonder about, is if somebody has already had a bleeding event, when can we start it? And I don't think this answers that question. I think this was a cool study in that they did look at post-op versus just medically managed ICH, and that is an area that we need more help in. I completely agree. I struggle to understand how these are new start antiplatelets when a very big proportion of patients had a clear indication for antiplatelet therapy, and I'm not sure that I understood exactly how they reached, maybe they like weren't currently on aspirin or something like that. Um, the conclusion that these were new patients with new antiplatelets. So I agree that this is probably a higher risk patient population.
Mhm.
Um, is your institution making any changes after this study? Does this like provide insight? I know you talked about future steps, but is there anything we can do based on this data for our current patient populations?
So definitely like not, I guess, like impacting, I guess, like the standardized protocol for starting new start aspirin. But I think like within like our clinical practice, I think this aids evidence and giving recommendations for resuming antiplatelet therapy for patients that were already on antiplatelet therapy. And it may be appropriate to resume. So showing, like referring to this study in that it was started at 3 days, and suggested safety, no difference in bleeding events. So I think that's how I would actually use it within my institution, when they are leaning more towards a more delayed resumption, when there's no other contraindication to resuming.
Yeah, I think that's reasonable. It's hard because the bleeding events were so low, so we don't know, if they had a few more patients, what that would have looked like, but at least there wasn't a big signal the other way. So thank you.
Thank you.
Does anybody else have any questions or any comments you want to throw into the chat? All right, so I don't know that this, closes the door on this topic the way I felt maybe with our other topic, because I think, it's very nuanced about restarting antiplatelets, but I do think that it does add to, our series of smaller studies telling us that we should probably be thinking about starting antiplatelets sooner rather than later. So
Yeah, I think there's
thank you.
definitely more to come.
Yes, I'm sure we'll continue seeing more studies. Thank you very much for the presentations. Thanks to both of our presenters who did a phenomenal job. And if you missed any of the presentation, feel free to go on X and continue the discussion and see some of the summary points there. So thanks everybody for joining.
Thank you.